Hey guys, how are you? So today I've decided to do a video on the osteology of the lower limbs. I'll exclude the bones of the foot that I'll cover when I do the foot and the hand together. So basically, each lower limb has 31 bones, that is including the hip bone. So we'll start with the hip bone, then we talk about the longest bone in the body, that's the femur, then we talk about the tibia and the fibula as well as the patella. So for you not to confuse yourself, let's just say the femur is the longest bone. It consists almost 26% of a person's height, then followed by the tibia, then the fibula. Those are the three main bones of the lower limbs, of course. Then the fourth one is the humerus, the fifth one we get to the ulna, then the sixth one we get to the radius. Despite the fact that we say the radius will have that stellate process that extends 1.9 centimeters beyond that of the ulnar bone. So we start with the hip bone, that is part of the pelvis as well as the lower limb, popularly known as the innominate bone as well. It has three primary ossification centers. That is one for the ilium, that is the most superior part, then the one for the pubis, and one for the posterior part, that is the ischium, posterior and anterior in relation, of course, to that acetabulum where the bones meet. The superior part, the superior 2/5, of course, is formed by the ilium, and then the posterior 2/5 by the ischium, then that anterior 1/5 comes from the pubis. So we'll start with the ilium. So basically we have that iliac crest, and it's divided into it has a ventral portion and a dorsal portion. The ventral portion is divided into three, and the dorsal portion is divided into two. So also of note, before I talk about those divisions, is that we have the anterior superior iliac spine that gives origin to the sartorius muscle. Then I have the inferior one that gives origin to the long head of that rectus femoris muscle. Then talking about those divisions, that are talking about the ventral segment. For it not to be hard, we have an anterior, then an intermediate, and a posterior part. So this anterior part gives origin to the latissimus dorsi, also giving insertion to the external oblique. So the intermediate part has to do with almost across its entire length, has to do with the internal oblique muscle. Then the other one, the last one, the most posterior part, has to do with the quadratus lumborum and the transversus abdominis. Those are the three layers of muscles that we talk about when we talk of the region of the abdomen. So it becomes a bit easy to take note of this. Then that's the ventral segment. Then we also have the dorsal segment, that is of course an anterior and a posterior division. Then from this dorsal segment, the outer segment gives rise to the gluteus maximus, and then of note, we also have the tensor fascia arising from the other anterior part of that ventral segment that I talked about earlier on. Then for that acetabulum is deficient inferiorly, where that acetabular notch that then becomes breached by the transverse acetabular ligament, with the head of the femur that forms 2/3 of a sphere fitting into this acetabulum to form that hip joint that we'll talk about in a moment when we talk about the femur. Then posterior to our acetabulum we find the ischium. Then this ischium, of course, more inferiorly, it forms the ischiotuberosity that gives rise to the gemellus inferior. Then this ischiotuberosity we'll also talk about when we talk about muscles of the posterior compartment of the thigh arising from this ischiotuberosity. Then as well as it's still muscle of the posterior compartment as well as the medial compartment, that's the adductor magnus. It also has a part that arises from this part. Then we also have an ischiospine that is going to give origin to the gemellus superior muscle. Then it also gives attachment to the sacrospinous ligament. The ischiotuberosity will give rise to will actually give attachment for the sacrotuberous ligament. Then The sacrotuberous ligament is the one that we sit on, of course. So not the sacrotuberous ligament, the ischiotuberosity, sorry. And this is more inverted in females than in males, where it's actually inverted. Then when you talk about the ischiospine, it's inverted in males and not inverted in females. Then when you talk about the the ischiopubic ramus, it is actually everted in males and inverted in females. Then we have the pubis, of course, that has a pubic crest and more laterally extending to give rise to that pubic tubercle. Then we have two rami, the superior one that goes to meet the ilium at the acetabulum. Then the inferior ramus that meets the ischioramus just below the obturator foramen. The obturator foramen, of course, is that space that we are, which is actually oval in shape when you talk about it in males and triangular in the females. However, it is more larger in males. Then in the midline, of course, at the region of the symphysis pubis, you find that subpubic angle that is 80 to 85 degrees in the female. Then it's 50 to 60 degrees in males. So for it not to be hard, just remember that most of the angles are larger in females when you talk about the pelvis. As well as when you talk about this, the larynx, we have a more acute angle in males that is around 90 degrees. I guess mine is a bit prominent, you can see. Then as for the females, it's around 120 degrees. But then that normally just changes when you talk about the carrying angle being 170 in males, then 167 in females. When you talk about the angle of the angle of the neck of the femur and the shaft of the humerus, of course, being 125 degrees, but then slightly less in females. So that's the innominate bone. I did talk about it having three primary ossification centers, and then it has eight secondary ossification centers. One of them being that for the ischiotuberosity. Then that's the hip bone. Then that's the pubic angle. It's more everted in males since it gives attachment to the crus of the peni. Then I need to talk about the acetabulum receiving the head of the femur, which I did say is the longest bone in the body, or the largest, if you may want to prefer it like that. Then so of this head, it has a central depression that is the fovea capitis that has the ligament of the head of the femur, properly known as the ligamentum teres femoris. This conveys blood supply to the head, and this blood supply arises from the obturator artery, which also is the artery of the major compartment of the thigh, which is a branch of the internal iliac artery, of course. Then this head, of course, it fits into that acetabulum. Then the acetabulum has a lunate surface that is on the lateral ends of our acetabular notch. This is the articular surfaces. Then the part that is in the middle is non-articular, and then I did talk about the transverse acetabular notch that is then breached by that transverse acetabular ligament. Then the femur will then have a neck that is oriented backward, that is downward, backward, and laterally at an angle, which then forms an angle with the shaft of the humerus of 125 degrees in the adults and 160 degrees in young children. However, there's also what we call the femoral angle of torsion, which is 12 degrees in females and 7 degrees in males. This angle is actually also large in the young. So it's the angle formed by the longitudinal axis of the head, the neck, and the gradation trochanter, with the transverse axis of the medial epicondyles of our femur. Then also on that we have that greater trochanter and the lesser trochanter, of course. So anteriorly they're joined by that intertrochanteric line that then continues posteriorly to give that spiral line. Then posteriorly the two have that intertrochanteric crest. The intertrochanteric crest houses that quadratic tubercle for that quadratus femoris muscle. That is one of the lateral rotators of That is one of the lateral rotators of the hip. Of course, most of the other lateral rotators, there's the piriformis, the obturator and teres, then there are two gemelli, they attached on the greater trochanter of the femur. Then just below the greater trochanter we find the gluteal tuberosity that receives a part of insertion for the gluteus maximus muscle. Then of course the greater insertion of the gluteus maximus will then fit into the iliotibial tract, which is a lateral thickening of the deep fascia of the thigh, that's the fascia lata. Then posteriorly on the shaft now, it's not smooth as compared to the rounded smooth part that we find on the anterior aspect. So this posterior surface has the linea aspera, which is a medial and a lateral lip. So the medial lip inferiorly continues as the medial supracondylar line, then the lateral one forms that lateral supracondylar line. Then the medial supracondylar line then joins the adductor tubercle for the adductor magnus, then continues as the medial epicondyle, then the lateral epicondyle also laterally from the lateral supracondylar ridge. Then inferiorly we find those condyles, of course, that are responsible for articulation with the tibia and the patella at the knee joint, of course excluding the more lateral fibula bone. Then still on our femur, it is one primary ossification center and 4 secondary ones. Then lest I forget, still talking of these ossification centers, the fibula is the only bone that goes against these laws of ossification. You can read more on that. I didn't quite get the part where they say instead of the primary ossification centers ossifying first than the secondary, the distal secondary one will ossify first than the proximal one, which has more to do with traction as compared to the distal one, which has more to do with support and etc. Then this linea aspera will give attachment to muscles. So for you not to forget, of course the vastus lateralis and vastus medialis, they're part of that quadriceps femoris. So they arise from, remember when we talk about still on that chart, remember when we talk about the triceps having a lateral head that arises from the upper part of the humerus, then the major head arising from the lower part. So this the vastus lateralis arises from an origin that is higher up than that of the vastus medialis, despite the fact that they both arise from the upper shaft of the humerus. Then vastus medialis will arise more medial than that of the intermedialis, despite the fact that it's intermediate and supposed to be between medialis and lateralis. I stand to be corrected on that one. Then that's just about it. Then for muscles, I did talk about the lateral rotators. Then I have the gluteus minimus, that the medius that goes to insert on the lateral aspect of that greater trochanter. Then the anterior aspect will receive that gluteus minimus. Then the lesser trochanter will receive that common tendon of the iliacus and the psoas major muscle, so giving rise to that iliopsoas tendon. Then that's the humerus. Then for that knee joint we find that kneecap, of course, that is popularly known as the patella bone, which is a burst that is oriented upwards, and then the apex of that triangle is down. So the patella bone is a sesamoid bone. It lacks periosteum. That is when you have damage and fracture, that we won't have union since it doesn't have periosteum. Periosteum. So my voice is becoming a bit weary due to the time that I'm speaking. But so this patella on the superior surface receives the tendon of the quadriceps femoris. Then inferiorly it has that ligamentum patella as it goes to insert on the tibial tuberosity. Then from this patella, it may have many ossification centers. And then you can have 2 or 3 forming a bipartite or tripartite patella. This clinically can be distinguished from fractures of the patella because it will be bilateral, not unilateral, where you have maybe you've injured your patella from the right side, then the left one will be normal. Then to to prevent dislocation of the patella, the body has adopted, or not has, but rather we were made that way, has three mechanisms of defense. One being that the lateral epicondyle the lateral epicondyle of the humerus is more prominent and protects the patella as compared to that of the medial. Then the vastus medialis is an extensive an extensive incision, or sort of, as compared to that of the vastus lateralis. Then we also have that medial retinacular of the patella being the third mechanism. Then yeah, then of course the vastus lateralis is on its lateral side, the vastus medialis on its medial side, the intermediate is just posterior to that of the rectus femoris, of course, but then they both have that common tendon, and the four, they both form that quadriceps femoris muscle. And then now on the tibia and fibula, our tibia is the more medial bone, and together with the radius of the upper limb, they form the preaxial bones. Then the fibula and the ulnar bone, they form the postaxial bones, of course. Then so this tibia has those tibial plateaus, the medial and the lateral one. They also correlate with the condyles of the femur, where they then articulate to form that knee joint. Then we have that intercondylar eminence that separates the anterior and posterior articular surfaces. Then on its lateral end, it articulates with the head of the fibula. The head of the fibula, of course, is the one that receives the insertion of the biceps femoris, that is a muscle of the posterior compartment of the thigh. Then, despite the fact that I said it's analogous with the radius in terms of being preaxial, in terms of its shape and tapering, it's analogous to the ulnar bone, that is also the medial bone of the forearm. Then posteriorly, it is that soleal line that gives origin to the soleus muscle. Then it has 3 bodies as opposed to the fibula that has 4 bodies. Then between the anterior and medial, we find that subcutaneous shin. Of course, we refer to it as the shin bone of our leg as well. Then the fibula has 4 surfaces and 4 borders. Then distally, they both prolong to form medial and lateral malleolus respectively, that then articulate with the talus bone of the foot to form that ankle joint. Then we have structures that pass structures that pass anterior to this bone, that is the the tibialis anterior, or should I just say the mnemonic is the Himalayas are not the Himalayas, and I've forgotten the mnemonic, but let me just say them. That's the tibialis anterior, the flexor hallucis. Then we have that anterior tibial artery. Then we also have the deep peroneal nerve, that's the nerve of the anterior compartment. Then we have that peroneus longus being the most lateral one. Then we have that flexor digitorum. Then we also have posteriorly, the mnemonic would be the doctors are not hunters. Of course, we have that tibialis posterior, that posterior tibial artery. Then we have the doctors are not, then the nerve, right, the tibial nerve. Then hunters. Then we have what else can we talk about there? Yeah, I think that's just about it. So I've tried as much as possible to make it a bit simple, but there is more to that, and I'll come back with a video on the foot and the bones of the foot as well, and the muscles. Then